Well, friends, we have been discussing and you have been witnessing a lot of growth of implants as well as joint replacement surgery being done with a whole lot of implants being used. But we have been discussing till date only the external pattern of bones and the shape of the bones, but not basing our knowledge on the internal architecture of bones. Actually, the trabeculae are a reflection of the stresses to which the bones are subjected to, and it's important that we also discuss what is the internal architecture so that we know the stresses to which the bones are exposed to. Well, historically, the first mention was by Galileo in 1638, and then later on, Monroe referred to the Galileo's important discoveries as applied to mechanics of beams. Diamel in 1743 published descriptions of internal architecture of bone which were very inaccurate, and then there were a number of publications subsequently. I won't go into the details because of shortage of time. And in Baugerie in 1832 published a book, but still, the written description and interpretations were very erroneous. And Van in 38 also was an English anatomist, and he was probably the first author to grasp the real significance of the overhanging of the head of the femur. But then he mentioned the trabeculae to be just either vertical or horizontal. So that was also very inaccurate. The concept of the compression and tension trabeculae was given by Jeffries Wyman, an American anatomist, in 1849. So it's more than 150, 160 years since that time, and nothing more has changed. Although I'll just come to it, and that this is very, very erroneous. These were two very important contributions by Humphrey. One was that the trabeculae and frontal sections arise from the articular surface of the head of the femur, are perpendicular to the surface at all points. This is very important. And the second is that two principal groups of trabeculae intersect each other at right angles. This is very important, and that's also biomechanically very important. But the most important contribution is, I'll come to this again and again, is this Mayer-Kuhlmann model of Kuhlmann, the great Zurich mathematician and engineer, in a meeting in 1867, in a collection of preparations of various bones, gave rise to the famous Mayer-Kuhlmann model, and that was based on the example of a Fairbairn crane. And this is the Mayer-Kuhlmann model, where one side is fixed to a bar and the other side is free to go up and down like a pendulum, and one side is supported. And the stresses to which the bones, the stresses which arise are like this, There is this kind of a decussation, and this kind of a decussation, incidentally, we'll see as I move along my presentation. Well, Wolff, you know that Wolff's theory improved the technique of observations of his predecessors by making extremely thin sections, and he has proposed the famous Wolff theory that on the compression side, you have more of trabeculae being formed. So this was the classic which he said that on the law of bone transformation was published in 1892. It was Cox who recorded a lot of observations on the trabecular pattern, and he said that the maximum strength of bone is with minimal use of material, maximum strength is provided by the trabeculae. And he concluded that greatest efficiency and maximum economy of the weight of the bone is provided by the trabeculae being placed in the adequate directions. So this is just the historical aspect. The Singh's index, I'll come to this later, but this I think is very erroneous because it is based on just a two-dimensional picture in the AP view. We need to see any bone in a three-dimensional perspective. Only then we can know what the features are. So our initial, this thing was in 1988, where I had presented this paper in our Indian Orthopedic Association meeting, and this was awarded. We had studied the trabecular pattern of the greater trochanter because we wanted to have a contour plate applied to the lateral aspect, and we wanted to know what the trabecular pattern of this thing was. And subsequently, we had this cadaveric material of 300 femora, which some of them we selected, and then we studied the trabecular pattern, we studied the trabecular pattern of the greater trochanter, and we thought that it was divided into a superior group over here where there's a radiolucent area, another one over here, and then there were a group of trabeculae at this point and a strong trabeculae over here. And based on that, we have designed a plate for the proximal end of the femur. But the femoral head and neck, where the understanding is on only a two-dimensional perspective, these are so erroneous. You can see that this is the kind of picture given in books, that it's only based on an AP view, not based in a three-dimensional perspective. So three-dimensional reconstruction of the trabecular pattern of femur is essential, as movements occur in three planes in the hip. We therefore undertook a study of cadaveric femur, first for a better understanding of the trabecular architecture, and then to design an implant based on the knowledge gained. So we divided the femur into coronal sections, and into, so this was the coronal section, and this is what we already know. We know that there are these compression trabeculae. We know that there is tension trabeculae which are crossing over like this, and then this is this third group of intertrochanteric trabeculae. I'll come to this strong group. Just remember this strong group, this is going up, and this is another group going down. But this is an arcuate arrangement. If you see it, sections from the anterior side to the middle and going posteriorly, they are arches actually, and the anterior sections actually represent the anterior part of an arch, a column like that, and there's a posterior arch. I'll come to this again a bit later. And this is how the sections were studied by radiographs. And this is the arcuate arrangement which is there, it's like this. There are beams. All these trabeculae which you are seeing there are like beams. And these are the anterior beam going posteriorly and the posterior beam going anteriorly. And then you have an area which is divided trabeculae starting from here. And it is in this region we put in our DHS screw. And that's how the lag effect works so well. And it's very interesting that here also, like we have these beams crossing exactly at 90 degrees, These also, the trabeculae cross exactly at 90 degrees, like we have these buildings which we make. Then we divide it into oblique sections. And you can see we studied it by naked eye observation and by taking X-rays. And again, you see the same arcuate arrangement here. Can you see this? Trabeculae going from here, going backward, and from here going forward. So the AP view ones are because of the movements of adduction and abduction. These ones which are taken obliquely are because of the rotational movements occurring in the head. So you see the same arcuate arrangement in the oblique sections. And this is the arcuate arrangement which you see. And then if you see the sagittal sections, you see the movements of flexion and extension, and again the same arcuate arrangement is seen in this view as well. See, these trabeculae coming from anterior going posteriorly, and from the posterior side going anteriorly. So see this arcade again. And so this arrangement is seen in the hip in three directions, because movements occur in the hip in three directions. And similarly, you have this, like I told you, an arcade arrangement which is there. And if you see this tunnel inside, this, the bottom portion is devoid of trabeculae, and because of that, the lag effect works so well. And if you take these sections like this, it is like an arcade. That same arcade, the same arches is like that, from the front. If you just go on seeing and following this arcade from here upwards, this is the anterior column. Like this, you can see this. The intertrochanteric trabeculae are actually these columns which are there, these columns which are there, these columns which are there, which are going like that, and which is coming in front. And if you follow it like this, you have a tunnel, an arcade which is going in. So that is the three-dimensional this thing, and based on this, we have come up with an implant for the lateral side, contoured around the lateral aspect, and we won't go into the details of this, but now we've been using this for all varieties of subtrochanteric fractures with very good results. Now, we must consider that trabeculae are not of bones, because it's the movement of the joint which is occurring. So do we study just the trabecular pattern of the bones or that of the joints? So if you see this, you have trabeculae which are going right across over here. So the compression trabeculae are followed across into the ilium. And if you see the tension trabeculae here, they divide into an anterior column and a posterior column. The anterior one goes into the anterior, the superior pubic ramus, and the posterior one goes here. So there is a continuity of trabeculae across the joint. Similarly, this is another one. Then we studied the lower end of the femur, again into this, and the lower femur movements occurring in the knee is only in sagittal plane. So here, the trabeculae, that same kind of a feature is seen only in the sagittal sections, as you can see here. The same feature is seen of decussation of the same arching network only in the sagittal sections. And here you have these trabeculae which are placed like this as onion peeling effect in the transverse sections. And one very interesting feature is that the medial condyle is devoid of trabeculae in the anterior part. So all your screws should actually be engaging the posterior part of the medial condyle rather than being placed straight. So all implants which are designed for the supracondylar fractures and all should have this feature where the screws should actually be directed towards the posterior half of the medial condyle rather than the anterior half. So we have designed this implant and we have been using this as a hockey stick plate. This was designed in 91 and I presented this long back. And the proximal tibia also has these trabeculae where you have this weight bearing zones. So the same onion peeling is continued over here across the knee joint. And this feature in the sagittal sections, in the proximal tibia also, you'll find that same decussation is there. It's trabeculae going posteriorly and this trabeculae going anteriorly, the same, and that's only in the sagittal section because movements occur only in the sagittal planes. Now coming to the ankle, this very important thing is the lower end of the tibia and the trabecular pattern of the talus. We studied that. I won't go into the details of this, but when we see this, that trabeculae are somewhat like this, You have trabeculae arising from the posterior part of the lower end of tibia, passing through the head to the body of the talus, upper part of the body of the talus, then it is continued to the navicular and the rest of the foot. And from here, trabeculae go across like this. So this decussation takes place in the body of the talus. And we studied the sections also, and we've come up with findings based on our study of the talus and the calcaneum, these sections. And you see here, again in the calcaneum, you have this decussation in the sagittal plane. See that over here. So then we've studied the rest of the foot as well, but what is most important for us is to see what happens when the movements are lost. So one thing is that why study this trabecular pattern? We have found that it's very important to study the lines of the fractures, fracture lines or the personality of the fractures. And we found that fractures usually occur between a thick trabecular zone and a sparse zone. The space in between, you have the thick trabeculae and the sparse zone. So the fractures actually occur there. Wherever you see that fracture lines are based on that. See, that's intertrochanteric trabeculae, and distal to that you have the fracture lines. So majority of the fracture lines occur through that. Even when you have this, as a separate fragment, this is the line where you have the breakage of the lesser trochanter. Now we said that even the Baumgartner theory is wrong because you have to place your screws where you have the maximum decussation. So that's the maximum hold which is there, and once you have it, even a smaller screw not going up to the tip, not following the Baumgartner, but if you can engage the place where you have the maximum decussation in the AP and lateral one, that is the place where the screw placement should be there, not based on just being 1.2 centimeters away from the tip. So this is what we are propounding, that in the AP view and in the lower end of the femur, that's where you have the fracture lines. Sparse zone and thick trabeculae. So here, everywhere, the Mayer-Coleman model I've been able to demonstrate to you. That's very important, and that should be studied. And we studied what happens in ankylosed joints, So once you see this, we found that this pattern is lost. Now you see here, you don't have any tension trabeculae over here, but you have a column of compression trabeculae straight down like that and from the medial side. So it disappears over a period of time. So these are actually not, inbuilt, but they are because of the forces of movements occurring over there. So you see this, the tension trabeculae disappears. And now in the lower end of femur, this is how the trabeculae is across the knee joint. And we found that this is what happens. Even in this is one column and the other column of only weight bearing. If you see this in the lateral view, you don't see the decussation here over there, and this is also disappearing. So in long-standing cases, all this disappears. So again here, even over there in the ankle, the decussation disappears because of the ankylosed joint. So we conclude that the study of the trabecular pattern of bones gives a clear understanding of the stresses and strains to which the bones are subjected to under normal and abnormal conditions. And applied biomechanical principles of joints can hardly be understood well without discussion of the trabecular pattern. Because of shortage of time, I'll stop at that and I'll invite questions. So can you just shut that off? No, actually, till date, I don't have a publication